Clinical Case Scenario Part 2. This is Professor Maha Shahin. A 50-year-old male complains of red eyes. He woke up in the morning with the lids stuck together. He has no history of pain or photophobia or itching. What is photophobia? What is the differential diagnosis of photophobia? What is the value of history of itching in this case scenario? Visual acuity of both eyes is 6/6. Examination shows discharge in the inferior fornix of each eye. Bulbar conjunctiva shows injection more pronounced in the fornices and less near the limbus. What is this injection? What are the causes of this injection? No pre-auricular lymphadenopathy. What is the value of examining the pre-auricular lymph nodes in such condition? Remember that adenoviral conjunctivitis is a very common and highly infectious disease. It is associated with enlargement of the pre-auricular lymph nodes. Ocular tension is 14 mm mercury in both eyes. What is the normal range of intraocular pressure? What is the sign seen in this slide? This slide shows the conjunctival injection. The injection is mainly towards the fornices and is less towards the limbus. So this is conjunctival injection. What sign is seen in this slide? This slide shows the discharge. The discharge is seen gluing the eyelashes together and is seen also in the fornix. What is your diagnosis? And it should be a complete diagnosis. So, if your answer is conjunctivitis, you get half the mark. This is a case of mucopurulent conjunctivitis. What organism causes this condition? What is the treatment of this condition? What are the complications of this condition? Another case. A 22-year-old patient came to the outpatient clinic complaining of burning sensation and itching. The condition started when he was 5 years old, with gradual onset and intermittent relapsing course. Both eyes are affected equally. The symptom is associated with redness, ruby discharge, lacrimation, and photophobia. The condition increases in summer and spring and improves in winter and autumn. He has no history of other general disease, and examination reveals this picture. What do you see in his averted upper eyelid? This is the classic picture of flat-topped papillae. What is your most probable diagnosis? What signs and symptoms of the patient support your diagnosis? Itching is usually associated with allergic conjunctivitis. Ruby discharge is usually associated with allergic conjunctivitis. The seasonal variation is associated with allergic conjunctivitis. What is the treatment of the acute stage of this condition? What prophylactic treatment are given to prevent the recurrence of this condition? What corneal pathology may be associated with this condition? Don't forget that keratoconus sometimes is associated with allergic conjunctivitis. What are the complications of prolonged use of steroids in this condition? Another case. A 5-year-old boy has history of atopy. He started using prednisone for flaring up of his eczema. His mother brought him because his right eye is red and painful. What is differential diagnosis of acute red painful eye? He had similar episode during last summer vacation on the beach with his family. The right eye is injected. Staining of the cornea with fluorescein shows a dendritic pattern. What is your most probable diagnosis? Dendritic pattern is diagnostic for herpetic corneal ulcer. Is it related to the prednisone treatment? Yes, because in cases of decreased immunity of the patient, there is recurrence of the herpetic ulcer. For example, using steroid treatment, or in adult females during menstruation. It is characterized by recurrence. So the patient had similar episode before. What sign is seen in this slide? This is the typical dendritic appearance stained by the fluorescein dye. Note the blue color used to examine the stained cornea. The area devoid of epithelium appears green. A 60-year-old woman came to the emergency department of the ophthalmic center complaining of pain in the right eye. As you can see, the eye is red. She had no previous episode of similar nature. What's your diagnosis? What is seen in the anterior chamber? Yes, this is hypopyon. So this is hypopyon ulcer. What is the most probable organism causing hypopyon ulcer? What is the treatment of hypopyon ulcer? What is the differential diagnosis of acute red painful eye? What is the differential diagnosis of acute red painful eye with diminution of vision? A 60-year-old woman complains of tearing and pain in her left eye. She had no history of trauma or surgery of the eyelids, nose, or sinuses. She had tearing and discharge for several months. Pay attention to the duration. She has this complaint for months, for several months. This is a chronic condition. This is not an acute condition. Recently, she developed a painful red lump near the left inner canthus. Examination showed her vision to be 6/6 in both eyes. There was an erythematous swelling over the left lacrimal sac. This slide shows the clinical presentation of the patient. Note that the upper and lower eyelids shows redness in addition to skin over the lacrimal sac. This patient is in acute exacerbation of the condition on top of chronic dacryocystitis. What is the treatment of this patient? Dacryocysto-rhinostomy is the treatment of chronic dacryocystitis, but not in this stage. First, you have to control this acute stage by medical treatment, and then you can do dacryocysto-rhinostomy when there is no acute inflammation in this area. A 30-year-old man had a painless lump on his left lower lid for months. When he saw it was enlarging, he saw an ophthalmologist. His vision was 6/9 in both eyes. A slight rubbery, non-tender mass was found. When the lid was flipped, slight erythema could be seen at the base of the lesion. This slide shows the clinical presentation of the patient. Note that the skin over the lesion is within normal. No signs of acute inflammation. And this is consistent with the complaint of the patient that he has this mass for months. Note the site of the mass. It is not related to the lacrimal sac. What is your most probable diagnosis? Yes, it's a chalazion. What are predisposing factors for chalazion? Please don't forget errors of refraction and eye strain as a predisposing factor in young age populations. And don't forget diabetes as a predisposing factor in older age populations, especially if it is recurrent in different sides of the eyelids in both eyes. But what if it is recurrent in the same site? If it is recurrent in the same site for more than 3 times, then you should consider tumor and you should send this mass for pathology. What is the treatment of lesion? A 56-year-old woman was presented to the emergency department with sudden loss of vision in the right eye, intense eye pain, headache, and vomiting. There was no history of any eye problem except for glasses for hyperopia. What are the ocular complications of hyperopia? The visual acuity was dropped to counting finger in the right eye and was 6/6 in the left eye. The right eye shows circumcorneal injection, diffuse corneal haze, shallow anterior chamber, and mid-dilated fixed pupil. This is the clinical presentation of the patient. Notice the corneal edema, the shallowness of the anterior chamber. The anterior chamber is the space between the cornea and the iris. The depth of the anterior chamber is estimated by examining the distance between the light beam of the cornea and the light beam at the iris. The pupil is myotic and the eye is angry. The lens is clear. The left eye was normal except for a shallow anterior chamber. The intraocular pressure was 36 mm mercury in the right eye and 14 mm mercury on the left eye. Fundus examination and gonioscopy in the right eye was not possible because of the extreme corneal haze. Examination of the left eye revealed normal cup-disc ratio of 0.2 and the gonioscopy of the left eye revealed a narrow angle. What is your most probable diagnosis? Yes, this is a case of acute attack of angle closure glaucoma. What is the predisposing factor in this patient? Hyperopia, shallow anterior chamber. In cases of angle closure glaucoma, it's hard to examine the angle of the affected eye. So you can examine the other eye, which gives a very good idea about the affected eye. What is the cause of vomiting in this patient? Vagal nerve stimulation. Another case, 67-year-old white man presented to the outpatient clinic at Mansoura Ophthalmic Center. His chief complaint is progressive, painless, bilateral, asymmetric visual loss over several years, What are causes of gradual, painless diminution of vision? Do not forget cataract. Do not forget diabetic retinopathy. Do not forget primary open-angle glaucoma. Examination reveals vision 6/60 in the right eye and 6/18 in the left eye with normal pupil. Intraocular pressure measured by applanation tonometer is 28 mm mercury. And this is how the optic disc looks like. Note the large optic cup. The cup disc ratio is 0.8 with displacement of the retinal blood vessels to the nasal side. What is your most probable diagnosis? This is a case of primary open-angle glaucoma. What is your treatment? What does the ophthalmologist examine in this slide? This ophthalmologist examines the angle. He is performing gonioscopy. He is using the slit lamp in addition to special lens for examining the angle. As if he is sitting inside the eye to see the different structures at the angle. The angle may be wide open, as you see in the right part of the slide, and the examiner is able to see the ciliary body, or it may be totally closed where no structure could be seen between the cornea and the iris. What are the investigations of a case of primary open-angle glaucoma? What investigation is seen in this slide? This slide shows perimetry. Perimetry is used to examine the visual field. How can you examine the visual field in the clinic? Visual field may be examined in the clinic by confrontation test, which gives a rough idea about the field of vision. What other investigation needed in case of primary open-angle glaucoma? OCT of the nerve fiber layer to know the thickness of the peripapillary nerve fiber layer. This is the OCT of the peripapillary nerve fiber layer in case of glaucoma. This 1-year-old child was referred from the pediatrician for crossed eye, as you can see in her photos. Her birth history is normal, physical health is good, and both right and left eye cross inward. Each one of them about 50% of the time. So this is an alternative squint, meaning that one eye takes the fixation and the other eye is squinting, and then they alternate their position. Examination reveals normal fixation and following behavior. The child can alternate between right and left eye. Refraction reveals minimal hypermetropia. Corneal light reflex is asymmetric, centered on each cornea. Cover test shows movement of each eye on examination. What is your diagnosis? This is alternating, concomitant, convergent primary squint. Why alternating? Because both eyes alternate with each other. Why concomitant? Because there is no paralysis of the extraocular muscle. Why convergent? Because the squinting eye is inwards. Why primary? Because there is no cataract or corneal opacity or retinal pathology that causes secondary squint. She has large angle esotropia with alternate fixation. Her refraction is normal for her age. Corneal reflex confirms the diagnosis of squint and used to estimate the angle of the squint. Ocular movement should be done to differentiate concomitant from paralytic squint. Do you expect amblyopia in this patient? What is the treatment of this particular patient? What are the important clinical points during examining a case of squint? What is the differential diagnosis? First is pseudostrabismus. What is pseudostrabismus? Pseudostrabismus is apparent squint. The child appears as if he is squinting, but actually he is not. By using the corneal reflex test, we can see that the reflection of the light is in the middle of the pupil in both eyes. So this is apparent squint. Accommodative esotropia. In fully accommodative esotropia, the squint is corrected by glasses. If it is partially accommodative, then the treatment is glasses followed by surgery to correct the residual part. Don't forget congenital sixth nerve palsy as one of the causes of esotropia. Note the limitation of movement of the affected eye towards the temporal side. This is a congenital sixth nerve palsy. Good luck.